there's a company that has a particular meeting that they talk about. It's a pony meeting, because you can go to that meeting and you can say, I want a pony, metaphorically, and the meeting's full of smart people, and sometimes what gets invented at that company is, in fact, the iPhone, right? A computer on their hip. So Steve started today by saying that they assembled a room of the smartest people they could find in healthcare, maybe in the last kind of minute and a half each. I'll ask each of you to give us your I want a pony around big data. We've shown that there's a lot of debate, a lot of opportunity, but if there's something that other companies in the room or entrepreneurs in the room could actually give you guys as big data healthcare professionals, what might that be? You want to go first?
Yeah, I mean, I think the very best companies come from problems that we ourselves want to solve. Think about any loved one who's been in an emergency room, gets, anything, every different aspect of this experience is something which could be remarkably improved, both by the time you spend waiting, the ultimate way in which a diagnosis is made. I have a friend who just went in the emergency room and was diagnosed with a blood clot in the bottom of his leg. We usually don't treat that with anticoagulants. The doctor said, well, I don't know, we might want to use an anticoagulant to thin your blood. I said to him, well, what did they tell you was the risk of the anticoagulant? He goes, well, when I asked him, they really weren't sure for me as an individual, given my age. They couldn't give it to me. And I said, what did they tell you was the risk without being treated? He goes, well, they didn't really say. They just thought I might be better off being treated. And that's just one small aspects of healthcare where someone's getting down trying to make a shared decision, and you're doing it in a data-free environment where someone's saying, I don't know, it's my inclination that you'd be better off being treated. But they can't even reflect on any made-up numbers, let alone numbers that are built from any large big data. I mean, they didn't even have the dignity to say, I don't know, 5%, whatever. But, so you're left with a feeling like, well, what is going on here?
So you want data in the pocket of the people
at the point of care where they can really give people guidance around making decisions.
What do you want, Andy?
Yeah, I guess I'd say we are, I think about, we got to focus on how do we take care of the old, the poor, and the sick better. I mean, that's where the crisis in this country is. It ain't on making that kind of the 1%ers 5% healthier. That's not what's bankrupting Medicare. That's not where the challenge is. And a lot of that's going to have to get done in care settings that don't yet exist today. They're going to have to get done in communities. They're going to have to get done in people's homes. So it gives us an enormous opportunity to design a way of getting information to people, and it's not all that complex in many cases. It's does someone who got a prescription have the ability to pay for it? Do they have a transportation to get where they need to get? And how might we facilitate that? That data problem is one that companies like Verizon, for example, and others in this room probably can apply some new thinking to. And I think otherwise, we could end up in a situation where we are kind of overcomplicating processes that need to change anyway.
So open our healthcare, usually overcomplicating things, minds to solutions that other people have figured out in other industries.
Yeah, I think we're all organized about empowering this revolution. And I don't think most of us, I certainly can't, can see what it'll be like in 10 or 20 years. But I think we're pretty confident that it won't be like it is now, right? that the PC big Somoclo revolution will take over all this stuff. So we're all about empowering that change. If you want to get some data from somewhere to somewhere else, huge impediment. Doctors just don't share data. Some of that is competitive, but most of it isn't. It's just too hard. You can't send an email to somebody else just because you're referring, because it's illegal. Why don't we just make that legal? Not by changing the law, but why don't we embrace the privacy and security? So we've got systems out there who's meant to say, use this exchange, we'll get the data where it goes. Let us worry about compliance. Let us worry about directories. Let us worry about identities. Let us worry about all that stuff that's hard. You share the data. You're going to refer the patient to the other doctor anyway. Why don't we just keep it digital? 88% of the data that goes from one doctor to another this year goes on paper or fax, right? There's no possible use of keeping it digital. If we just empower the digital, keeping of it, we at least give entrepreneurs a chance to innovate around that and make this change that's happening.
So clearly you get a couple people.
I made up that 88%, by the way.
That's what happens with big data.
It's in the high 80s.
Garbage in. So you get a couple people who are passionate about big data together.
You all believed me, didn't you?
You put us in the same spot. Clearly, you've got a lot of passion, a lot of disagreement, and I think the word revolution is a good one. I mean, I think if anything, I can assume that we all agree that things are going to be different. Let's try to sum up this stuff in terms of actionable things. So we need better information at the point of care that is actually assembled using the right techniques and not our traditional healthcare paths of making things overcomplicated. Is this the right message to give to this
Can I
audience?
just give one area we haven't talked about, though, that does interface with yours, which is this issue of comparative effectiveness. So we've talked a lot about how can you tell strategy A or strategy B. We heard in the first group about how industries are overspending on phase 3 studies, and you saw this list of companies for particular products who put all these together. Pfizer, I was amazed, 31 phase 3 trials for Lipitor. But we never did really have a head-to-head outcomes trial of Lipitor versus another statin to know whether or not there was actually any difference between Lipitor and the results that it was achieved based on patient outcomes. So then you're saying, well, if industry's never going to pay for that, why should they? It was a blockbuster drug. Why should they put it under any vulnerability of a large trial like that? So what are we going to do with big data? To what degree can we use big data to begin to make inferences about products head-to-head, and to then be able to inform patients as they're making choices, understanding what the cost implications are? We're talking about generics. We're going to roll out big generics. One of the generics for atorvastatin was just pulled off because of concern about contamination. But how about effectiveness? Are these generics exactly the same? What are we going to do to study to ensure our confidence in it? Because they're made slightly differently. Are we going to embrace them?
This is an ideal case for big data. We manage a transcription company's data, and they have 6 million patients among 7,000 doctors. There was a question between two drugs built by different pharmaceuticals that were competitive. And the one was going to do a post-marketing trial that was going to cost them $30 or $40 million to try and remove a label restriction. We said, why don't we just look at this data? These people already take this stuff. We found 7,000 plus patients in each group, roughly, just by looking at the data that existed in the database. Who were comparable. And we got the answer for them in 3 weeks. Right? And it cost $100,000 if you really loaded it up, not $20 million for a phase 3 post-marketing study.
Is comparative effectiveness the wrong label? Should it really be comparative value? I mean, isn't that, Andy, what you need to find out?
Well,
use your mic.
So, that's all pretty politically charged, but I think the bottom line comes down to this. If you've got a wonderful cure-all biologic drug that's $100,000 in annual costs, but it only works in 1 in 5 people, who here thinks that the country, private employers or CMS is going to pay for that drug for all 5 people if it only works in 1?
You got to figure out which one.
So you got to figure out which one. So you got to be able to focus and invest in diagnostics. You got to create payment models that reward it when it works, doesn't pay for it when it doesn't work. Then you'll start to build a culture of data around that problem.
Now, your bigger problem is 1 in 5 is a pretty good deal. No one's going to deny that. But what if it's 1 in 500 for that one person? It's a remarkable cure for $4.99. It's nothing. I mean, when you start putting it like that, it's going to be a challenge. But then you start saying, how do you inform the science, the basic science? Like you said, go big and say, now how are you going to figure out what the markers are? But I think, the larger question is how much are we going to be able to invest in understanding where the real value is in the healthcare system and using the data to power that.
So in my quest to get us to agree on something before we end our session, so let's go with the assumption that medicine is biology and that is too complicated to always know the right answer, to your point about that particular therapy. The idea of bringing this information together in a broader, countrywide, if not global way, leveraging what we've learned in other industries to put better information in the hands of patients and their healthcare providers is something that the work that people like the 3 of you are doing is going to provide.
We hope.
I'll salute that too.
If you put control in the patient's hands, they'll give you permission the vast majority of the time.
Because they feel like they're in control of their own outcomes.
Absolutely. If you put control of their data in their own hands, the vast majority of people will say, of course you can use it for research. And you know what? You don't need 50 or 40 or 20% of patient data to get good research. You need a trivial fraction of that to get great answers.
So is the biggest source of healthcare information in the world Twitter or Facebook?
Social media, in the end, is a great source of medicine.
I think Harlan and I probably would, I'm guessing, would have the same answer. It always depends on what question you're trying to solve.
Yeah.
Harlan?
Yeah, it depends on the question. I mean, it does turn out that people who are searching for influenza on Google gives you some sense of what's going on epidemiologically, but it's a crude look. It gives you some kind of a signal, but I absolutely right, Andy. I mean, it depends with what question you're asking, with what degree of fidelity do you need to know the answer, and what are the consequences of that decisions that are being wrong with using that kind of data. But I think what we're all saying is that we're at a remarkable juncture in history where information and data are available in volume and timing that's unprecedented. Our challenge is going to be to use it wisely, recognize that it can have unintended adverse consequences, but that it can also be used to power fundamentally what the new age of healthcare is going to look like.
Responsibly and in collaboration, putting the patient at the center of a universe which is theirs, surrounded by specific information related to what is going to make them better based on the decisions that their healthcare provider has, surrounded by a bigger sphere of medical information that allows us to intuit possible outcomes in larger populations, potentially even surrounded by an even bigger universe of information coming from the people who are putting cell phones in their pockets and their social
And
media
elevating our
outlets.
systems that are supporting it. Yeah.
Gentlemen, we ran out of time. Thank you so much. It was a pleasure speaking with you. Thank you for your questions. Thank you, ladies and gentlemen.